Oh, well, we'll give it a minute or so for everybody to join. So. Just one more minute for everybody to join. Okay, a couple more seconds and then we'll start. Okay, so I think we'll start. So hello all, and thank you for joining this afternoon. As always, we really appreciate your time, and we hope you're going to find this session useful. So we're aiming to open up a conversation about a very important subject today, which is a strategy for patient equipment cleaning and decontamination. And I'm delighted to say that this time we're joined by Amy Hill, Hotel Services Manager at Royal Wolverhampton Trust. Hi, Amy.
Hello.
And then Corrado Gilbert, our own Regional Manager for Midlands. Hi, Corrado.
Hi, Tazis. Thank you.
So we will be holding a Q&A session at the end of the presentation. So please use the question box to post any questions, as we will aim to answer as many of them as we can. Can I have a next slide, please? So here at Inivos, we specialize in developing technologies and services that reduces the risk of infection in clinical environments. And our aim is to enable care environments to deliver better care faster. And in order to achieve this, we follow this three-step approach. So we want to understand the challenges that clinical environments are faced with and use all this knowledge so that we can design solutions that meet the need and allow us to deliver these measurable results. And this content of this session is a great example of this approach. And with this in mind, I'd like to hand over to Corrado.
Thank you, Tazis. Yeah, so what we'll be going through today is really an example of our approach, our understand, design, deliver approach in action at Wolverhampton. And I suppose going back, winding the clock back to 2011 was when we started working with the Trust. I think one of the reasons we've really enjoyed working with you, Amy, at Wolverhampton and your other colleagues is that you've always had an appetite for research, which has always led to some exciting data and things we've published together at a number of conferences. Now, I suppose for a number of years we've been working with the HPV decontamination. More recently, we've done a piece of research around the UVC decontamination of the patient environment. But more recently, what we've been really impressed with is how you've been able to act with a clear head in a time of confusion, really, there at the Trust to implement something very innovative around patient equipment cleaning and decontamination. And I suppose it started back when, well, I don't know when we started talking about this, it would have been some time ago. But I suppose we had a number of challenges that we were faced with, or you were faced with at the Trust. Particularly, I suppose one of the first challenges that was a growing concern and a growing frustration was the lack or the inability to access whole wards to maintain and uphold your deep clean program. Is that right, Amy?
Yeah, that's right. We did at one point have a decant ward that we were able to utilize for our proactive deep clean program. However, due to regular capacity pressures, we ended up losing that. We struggle every year to try to find a suitable alternative. We generally tend to find some sort of solution, but inevitably we always end up having to do a couple of wards in a bay by bay rolling scenario, which is not the ideal way to deep clean an area. So you simply don't have the ability to get into everywhere that you need to get if there's patients in a day room or somewhere waiting for you to finish that room off.
Yeah, and I think you're dead right, and you're definitely not the only trust. We work with over 120 organisations up and down the country, and there's only a small handful who've been able to maintain that whole ward deep clean and decontamination program. So you're definitely not alone in that. And I suppose another challenge you were facing there was around the I suppose when we were in the thick of the COVID months, and we were looking for other roles, weren't you, around how we could reposition some staff into non-patient facing areas. Can you tell us a bit about that?
Yeah, we obviously before the individual COVID risk assessment requirement from the government came out, like everyone else, we listened to our staff's concerns, got occupational health involved, and kind of did the informal risk assessment approach. So if someone had an underlying condition or met criteria that we knew would make them more susceptible to encountering difficulties if they acquired the virus, then we're moving them off of patient-facing roles. And there was only a certain amount of non-patient facing roles or areas that we could redeploy staff to in order to keep them safe. And we certainly, in the middle of the COVID crisis, when we had our peak numbers here at New Cross Hospital, didn't want to furlough anyone because we needed all the help that we could get, just like everyone else did. So this project helped to create additional non-patient facing roles for members of staff that required them.
Yeah, certainly. And there was quite a large group of staff, wasn't it?
Yeah, at one point we had 20% of our workforce, so 1 in every 5 were off either shielding and had shielding letters from their GP, or they were symptomatic or having to self-isolate due to a close family member, someone under their roof being symptomatic. And then we add onto that challenge, we had quite a few members of staff that did require the non-patient facing roles. So we had quite a lot of staffing challenges, as well as bank staff deciding that they didn't want to come to work anymore, which of course they had every right to do that. So got through it, but we needed to be creative.
Yeah, no, good for you. Well done. And I suppose another challenge that we've been seeing is, or I suppose has been a concern really, is the quality of the cleaning we've been able to complete, or your team have been able to complete when we're carrying out cleans of a bed space in situ, and when we've still got other patients in the same environment.
Yeah, that's right. We have a dedicated bed cleaning team here that would clean a bed space once a patient had been discharged before the new patient came in. However, when you do that on the ward, there is always the pressure that there is another patient on AMU or wherever they are waiting to go into that bed space. And as you all know, it's just, while that pressure is there and they're telling you they need that bed space available, things inevitably get missed. The hard to reach places don't get as good of a clean. And all we were able to really do is clean the bed spaces, manually clean them. We weren't able to decontaminate, unless of course it was a barrier, then that was a little bit of a different situation. But sometimes we'd even get calls to clean a bed space in a bay in the middle of the night. And the clinical staff and capacity actually expected us to clean bed spaces effectively without the lights on. How that's possible really is beyond me. But that's the pressures that we face nowadays. It's the reality of the situation.
Yeah, and then from your staff's perspective, they want to be able to say they've done their best. So I guess we wanted to create an environment where they could do that and they could do a quality job consistently.
Yeah, and that's something that we've been talking about for a long time, is to be able to implement that.
So I suppose the last point here was around the C block, which is where we focus this program, isn't it?
Yes, the C block here at New Cross is our medical block. So surgical is another area. So we've always struggled a bit with infection rates not being where we want them to be in our medical wards. And obviously we do the PII meetings and the SI meetings, and we trace back in any infections and do infection typing. And we do everything we can to combat that, but that's always been an area where there's always a bit of concern.
Mm. No, that's really helpful to get that background on those challenges. So I suppose what we've been talking about for some time, and can you remember when this first kicked off, this conversation, Amy?
Well, actually, the first time the conversation occurred was before I even arrived at New Cross, and my predecessor was here, and it was discussed with my deputy as well as the chief nurse at the time, and they tried to implement this. Then shortly after I arrived at New Cross, about 3 years ago, you guys came out and we were talking about something else, but it was just brought up in the conversation that this is one thing that they've done in other places outside of the UK, and it really piqued my interest, and I was like, you know what, that's a really good idea. So that was around 3 years ago that I first started getting involved in trying to implement this. We just never were able to do so. We never had a physical place to do it, and we never had the extra bed stock. All the beds were always in use, so we never had the resources to purchase a ward full of mattresses and bed frames and patient chairs and over bed tables. We couldn't make it a reality.
Yeah. So I suppose in summary, what the program and the solution was instead of asking our domestic housekeeping staff to clean in situ, the program is that we take the equipment off the ward to a dedicated, focused off-ward deep cleaning and decontamination centre, what we've come to term the PEC centre, which stands for Patient Equipment and Cleaning Centre. And that gives our staff, or it gives the housekeeping staff, the ability to really focus and do a quality job consistently of thoroughly deep cleaning and decontaminating that patient equipment. And then that patient equipment comes in, is checked in, it gets deep cleaned, gets steam cleaned, it gets decontaminated, and then it goes into a clean holding area before it gets returned back out to the ward. So let's go into that program a little bit deeper and how you've made it possible, Amy, because as you said, it hasn't been easy for you to implement it, but what I think has really impressed us at Inivos is the way you've acted at a time when there was a lot of confusion and added pressure for the staff throughout the organisation, but actually turned the COVID challenge into an opportunity for yourselves, didn't you?
Yeah, well, it's like I said, it's been something that we've been trying to push forward for quite a while, and one day it just hit us. We said, do you know what, we've got a couple of empty wards that have beds on them. Why don't we see if we could trial this at least, for a little bit of time. Now, we did have to agree that if capacity pressures hit and they needed it turned back into an active ward, that we'd be able to turn that back around into a ward within a matter of a couple of hours and end the trial. But luckily, so far, we haven't had that situation occur. But with the closure of a lot of outpatient clinics, elective surgeries, and, and with the elective surgeries, the clinics, the pre-surgery clinics, as well as post-surgery recovery, it just freed up a lot of space for us to be, and beds for us to be able to do that. So C17 had recently been used as our original COVID ward before, when we thought the numbers would be a lot smaller than they actually were. It's not usually used a lot of times as a ward because it only has 17 bed spaces in it, and it doesn't have a lot of side room capacity. So It's one that's kind of used for almost like a decant ward. So if an area requires some estates work to be done, people might move into C17 for a short amount of time. And that's where we decided it would be ideal, because it had the 4 different bays that we required for our model. And it had a reception desk for us to answer phone calls and have our supervisors sit at and that sort of thing. So we said, well, that would be a perfect ideal spot. Plus it's right in the middle of the C block. So it was easy to get beds to and from all the different wards that we wanted to trial it on.
Yeah, yeah, sure. And I think the other thing you were telling us about, which I think helped facilitate this, is around your rezoning of staff and their responsibilities to reduce that risk of cross infection.
Yeah, this was something that we were looking at anyway, and restructuring our afternoon teams. But obviously when COVID came in, we needed to ensure that staff weren't cross-contaminating. And we really needed to ensure that they were based on the same areas. So traditionally, most of our cleaning at New Cross is done in the morning hours on wards. And then, you know, a top up and then touch up clean in the evening with a reduced service then. And in the afternoon, it's not a lot of staff. So we had different dedicated teams in the afternoon. So we had the bed cleaning team that I discussed earlier. We had a barrier team that would do barriers. We had afternoon toilet cleaners. And, you know, so it just seemed to me when I took over here 3 years ago, I said, this is a lot of wasted time and traveling back and forth in different areas. People were here, there, and everywhere, having to set up trolleys again every new place that they went to. And being a practitioner of lean made me realize we need to plan this better. There's a lot of wasted opportunity here. So we were already planning on doing that. And it was kicked into play immediately with COVID, because we needed to then redeploy them to where there was one person based on a ward in the afternoon that did all that. They did all the afternoon toilet cleans. They did all the bed cleans. They did all the barrier cleans on 1 to 2 wards, dependent on, you know, what the bed turnaround times and discharge numbers were on those wards. I apologize about my lights. They're motion censored, so please bear with me on that. So luckily, we were in a situation that we were already planning on zoning our staff when infection prevention had the word with us and said, listen, we need to do this.
Let's make it happen. Yeah, no, that's excellent. And I suppose what we wanted to get a better understanding of now, Amy, was exactly how you work your program. So what we've got here on the right hand side is a floor plan of the ward of C17. We've got some arrows demonstrating the flow of patient equipment into and out of the ward area. But it'd be great if you could just talk us through how this program works step by step.
Yeah, so once a patient is discharged and their bed is then deemed as dirty, we get notified as soon as the bed cleaners do in the patient equipment cleaning area. Runners are radioed by the bed cleaner, and then they take themselves off to the ward and to the bay, collect the bed. They collect the bed frame, the mattress, and put the overbed table and patient chair on top of that. They then take it back to the PEC center and they book it in and take it to the dirty storage. After that, they go to the clean storage and they take a clean set of equipment, book that out, where it's going, and take that back. By the time they get there, the rest of the bed space should already been cleaned. And the process that happens between getting from the dirty storage to the clean storage is once a bed is ready to be cleaned, it gets moved into the cleaning station by the team that remains on the PEC center. First, it gets steamed. And the main reason for this is anybody that's ever cleaned a bed frame knows how difficult it is to get into all the nooks and crannies of a bed frame, even without a patient in situ. There's areas that you physically cannot get a human hand into, that dirt and bacteria and all sorts of nasties can lurk in. So we steam the whole bed and it pushes all of that out, the steaming does. So once it's steamed, we then manually clean it with a chlorine and detergent solution. Then once that's actually steam cleaned and manually wiped down, it's taken into the HPV room. And once we receive the maximum capacity of beds that we need in there, we set off the HPV machines to decontaminate the beds. Once that's completed and the levels are safe and we go in, we get the bed, we pile all the equipment back on top of it the same way that it came in. We cover it with a mattress protector, and we wheel it into the clean storage. And so that cleaning station is really, the manual cleaning is a big key, because we clean all the different pieces, not just the bed frame. We check the mattresses for strike through, you know, all the patient chairs and the overbed tables, and give it a really good going over before decontamination.
Yeah, that's excellent. I think you've done a great job of implementing the model, and both, as you say, the importance of thorough cleaning, including the steam cleaning, which is often we see a lot of organisations have parked the idea of steam cleaning because of the time it takes, or attempt to do it in an environment where we've got other, you know, where it's not really fit to be done. But what we're seeing here is it's focused off-ward deep cleaning and steam cleaning, which really gets it to the standard of the quality we want it to before it gets decontaminated and can be taken back into the clean store.
That's right.
So if we move on now, we wanted to highlight the importance of having a great team, didn't we, Amy?
Yeah, and now all these people are the ones that do the manual cleaning on the C17 ward in the PEC center. And that's our HPV room. And these are people that needed to be redeployed off non-patient areas. But you know what? They're all so passionate about what they're doing, and they absolutely love it. The person in the middle there without the face mask, that's Gwen. She was a supervisor for the sterile services, but she worked directly for the trust, not for the sterile services company. And she is so passionate about this project. She really brings all the passion to everyone else as well. And she supervises them and coordinates it all. And she's been absolutely outstanding, to the point where she's actually given her notice at sterile services and is coming to work for us, you know, in our department, because she just loves it so much. And the team that's actually performing the work, you know, it can be very frustrating cleaning clean places and not really seeing the difference that all your hard work makes. And they love it because they can see the difference that it makes, and they know that what they're doing is really going to make a difference to the patient journey and you know, the families of the patients. And how nobody wants to stay in hospital for a prolonged amount of time. So they know that what they're doing is making a massive difference to, you know, patients not getting healthcare acquired infections. So they just love it. It's great.
Yeah, no, that's great, Amy. I think that's one thing that really impressed me last time I was on the PEC Centre, was that culture driven by the passion, and Gwen's got her team working together, and there's you can see there's just the passion is, you can almost feel it on the unit. It's great environment to be working in, and the team have definitely got a lot of enthusiasm for what they're doing. I think that's certainly been part of the success of this, hasn't it?
Definitely has. It definitely has.
Good. So in terms of the technology that the Trust are using at Wolverhampton within the PEC Centre, is the Proexide system. So this is a system that's been developed and is produced by Inivos, and we're working with over 120 organisations throughout the UK with this technology. And one of the key things that we see trusts engage over it for, or there's a number of key things. One of them is the turnaround time, so the ability of achieving a log 6 efficacy process within a 2-hour time frame, including the deactivations that's ready for safe re-entry, is a key factor. It consistently decontaminates to that standard in that it monitors in real time throughout the duration of the process the premises, what's happening in the room, to ensure that every time it runs a process it achieves the set parameters and is successful. And that's been validated down at Porton Down, the Public Health England laboratories in Salisbury. And then at the end of the decontamination cycle, it automatically generates a PDF process report, and that process report is cloud-based, but we set it up to come back to the organisation, to Amy's team there, so they've got a full audit trail, audit trail which they can refer to for any audits that are taking place or reporting that needs to happen. So there's that full track and traceability. And then, as you can see here on the screen, it's got a process monitor which is detachable from the unit. That sits outside the room and is the remote process monitor. So there's no need to be inside the room for starting the process or for terminating the process should that be required. And we've got a real-time update as to how much longer to go during the process. It's demonstrating that there on the screen outside. So this is the technology that Wolverhampton are using as part of their PEC Centre process. So coming on to the results, Amy, I think the results we've seen have kind of been quite far-reaching, particularly given this has been a very focused trial of the centre, trial of the programme on your C block. But I think some of the key areas we wanted to highlight here, one has been the increased attention to the quality of cleaning, hasn't it?
Most certainly, and that just goes back to what I was saying earlier, is cleaning in situ. It's too difficult with everybody on the ward breathing over your shoulder, watching, waiting, knowing that patient is probably in transit on the way to the ward. So they really have the time to thoroughly get in there and clean it the way that they want it to be cleaned, and that they want to do the job in that fashion and do it to their own satisfaction as well. And hopefully, while we're not able to currently monitor reducing the risk of infection based to COVID and other factors, as far as it's just not comparable to previous years this year, obviously. But there are certain things that we are able to monitor, and we've seen a reduction by 15% in the turnaround time for a bed space. So it actually reduces the amount of time that a patient has to wait for a bed once the other patient has been discharged.
Yeah. And to be really clear, Amy, that's your every clean or following every discharge of every patient, with the exception of your red cleans, so the highest risk organisms, which are, do you want to run through what they are?
Yeah, that's basically your main ones are C. diff and CPE. Anything that we would actually HPV the area. So we use this for, green cleans and potentially amber cleans.
Yeah, and the reason I wanted to highlight that is with a 15% increase in your reduction in your turnaround time of a bed space or of a patient room, with those cleans that are generally we're doing a disinfectant clean for, aren't we, on site?
That's correct. And in fact, the regular patient discharge isn't even a chlorine detergent based solution. That can just be warm soapy water if it's somebody that doesn't have any sort of infection. So it's not getting the same level of clean because it's been cleaned. It's not being cleaned as thoroughly because, as I said, there's areas that physically your hand can't get into. But furthermore, it's not being decontaminated.
Yeah, so that's excellent. So you've taken it from a detergent clean in some instances, sometimes a disinfectant clean, depending on whether it's an amber or green clean.
Mhm.
And we're actually taking that equipment away. It's being decontaminated, as well as steam cleaned, as well as thoroughly manually cleaned. It goes through that full process. So it's, in terms of the quality, significantly greater. And the freshly decontaminated equipment is taken back with a 15% reduction in that turnaround time frame. So that's an amazing achievement. I
Yeah,
think.
obviously it's always a balancing act,
Mm.
to balance between reducing risk of cross-contamination and infection that IP wants you to do, and bed turnaround time that capacity wants you to do. And we're always poised right in the middle, and this pleases them both.
So I suppose what we'd love to do next, is to actually introduce the red clean. So introduce this for C. diff and for CPE, where we've had patients with C. diff and CPE discharged from a side room, is actually take that equipment, take it away to the PEC centre, with some form of a shroud over it, and then that works through the PEC centre process, and and the runners take clean equipment from the clean zone and bring it to that space. So we were talking recently, weren't we? The current process takes around, is it 3 to 3.5 hours, 3 to 4 hours for a red clean in a typical side room,
Yeah.
with the traditional cleaning on the ward, cleaning on all the patient equipment in the room.
Yeah, and the fact that you know, most of our side rooms are en suites, so you've technically you're cleaning 2 rooms because you're cleaning the ensuite as well. You know, so it does take a lot longer to do that. So I would like to roll it out to that. We're currently, like I say, only offering the trial on the C block. We're only offering it Monday to Friday in the hours that the bed cleaning team used to operate. Anything outside of those hours, the bed space, unless it was a barrier, if it was a green clean, it was cleaned just by the clinical team. You know, so anything, normally our discharges didn't start until 11 or 12, you know, once the rounds have been done. So that's why we had already determined an 11 o'clock start time for our bed service anyway. And I'd like to roll that out to, you know, to incorporate the rest of the hospital, to incorporate weekends, you know, red cleans, and get it all done. I would like every bed that a patient gets in to be freshly steam cleaned, manually cleaned, and decontaminated.
Yeah, yeah, that's fantastic. So I suppose what we're doing in this process is we're taking some responsibilities of cleaning responsibilities away from the nursing staff, releasing their time to care, for patients, which is obviously what they're there for, and then also giving your staff the ability to focus on thoroughly cleaning, improving the quality, and we're taking the the performance benefit, I suppose, in that we're able to reduce the turnaround time by 15%, for those straight discharge cleans, the amber and greens. But on the red cleans, it's likely to reduce from around 3.5 hours to around 45 minutes, is what we're expecting, isn't it?
Yeah, that would be fantastic. Um, that's what I'd like to achieve. Yes.
So I think the last thing we were talking about, and we're hoping to support with, is around the implementation of an online portal where all that equipment gets logged in. So we move from a paper-based to electronic portal. So all that equipment gets logged in and it gets put through the PEC Centre process and then checked out at the end. So we can get some dashboards and reports which we can report into, or you can report into your environmental groups.
Definitely, and take that information further too. If you do have to attend a PII meeting or an SI meeting to do the track and tracing, of any sort of healthcare acquired infection, we are currently just, it's a paper-based system and putting the information in on Excel, but I'd love that to be on a portal with a dashboard and a database system to where we can just run a report on an asset number for a bed frame, because we've linked in with our medical physics department in order to be able to run a report to say, right, this bed was last deep cleaned and decontaminated on X date. It's notoriously difficult to track bed movement in a large acute hospital. And this is going to enable us to be able to do that and capture most of that information. Furthermore, we'll be able to track the mattress checking and the mattress auditing for strike through. So we were able to take that off of a lot of the nursing responsibility, because that's always been one of the things that they've been responsible for. But since we're cleaning the mattresses now and checking for strike through, it contributes to allowing them more time to care as well.
Yeah, no, that's excellent. So we had a couple of photos that you shared, Amy, around the before cleaning, which is just a very visual indicator of the impact. So that's before cleaning, and here is after cleaning. So we can see.
And those are stereotypical normal pictures. They're not the worst things that we've ever seen. You know what I mean? It's the bits that they don't have time to get to, the underneath, the stuff in the wheels, and you know, the surfaces that they physically can't get their hands into, and it just makes the equipment sparkle like it's new again.
It gives the team on the PEC Centre a sense of pride, doesn't it? Really.
Yeah. They really enjoy it, actually.
So I think in soon to round up, but we wanted to include some advice for other organisations, learning from what we've learned through the process at Wolverhampton, Amy. And I think your point that you keep referring to, which I think is great, is that we don't run before we can walk and don't walk before we can crawl. And that's the way we approach this service within the organisation.
That's right. You definitely have to set some parameters that you need to keep within to learn the lessons, because everything that looks great in theory doesn't always work well in practice. And you need to make sure that you haven't taken on too much initially, so you can learn those lessons. So any mistakes that you make or anything that you need to tweak, you can do so before you roll it out to the rest of the organization or the hospital.
Yeah, sure. And I suppose one thing we keep coming back to is about we need support from senior colleagues in the organisation, and we need support from the team on the PEC Centre, and all in all, be passionate.
That's absolutely right. And we've received some fantastic feedback from the wards. We're asking for their feedback. We're actively encouraging people to come up and go walk around the PEC Centre and see it for themselves.
Yeah, certainly. I think you made a point about the feedback you've been having recently.
Yeah, that's this next slide gives you, I mean, just one of several emails that I've received from a senior ward sister. I've gotten emails from loads of different wards that it's affected, the ward sisters, even the HCAs, it's helped them out. And all the feedback that we've received is very positive. The only negatives that we've encountered is that the service hasn't been fully expanded yet, that it's not available on the weekends, and that we haven't included the patient reclining chairs in the day rooms. And you know, but that goes back to the whole you crawl, then you walk, and then you run.
Yeah, exactly. We're looking forward to the next steps.
Definitely.
Good. Well, thank you very much, Amy. I think Tata, we wanted to.
Yeah, thanks, Hall. And it was really great to hear you both, and I really love your enthusiasm, Amy. So it's a pleasure to listen to, you know, the whole journey and how you got to these, you know, excellent results. So I think we still have some time to take a couple of questions. One of those is, if I just straight go into that, and I think it's for Amy. How did you get support from your senior management?
Well, we already link in with our senior management anyway, with environmental group and with, you know, just normal day-to-day running of the hospital. So my line manager, who's the head of hotel services, and I approached the divisional managers, and primarily the divisional manager for the medical wards, as well as the matron that was over the majority of the wards that this would affect, and we just sold the service to them. Like I said, there were some operational concerns that you know, what would happen if they needed it to convert back to a ward. So we're able to provide assurance to them about where the other equipment is stored and locked away, to where we could turn it right back into a ward within a very short time frame, within a couple of hours, if need be. And furthermore, the other main concern that they had, and that we've had, and I think other people have had as well, is that equipment walks. When departments know that there is an area with working equipment and working beds just sitting there, that it tends to walk. So we have very tight security on this ward. We've actually physically had people break through chained, padlocked areas before, which is just ridiculous. So we have swiped access that is only allowed for a certain number of people, but then we also physically padlock the ward at night when we're not there. And furthermore, the equipment on the ward that is not part of the decontamination, we've got locked away in the side rooms and the storage rooms on the ward. So it's there. We're able to pull it out when it's a little bit quieter and give it a wipe over, so we can maintain the cleanliness of that equipment. So if it is needed at any time to go back to a ward, we can immediately get it out there. It's already in a clean state, and it can be transferred straight back into a ward.
Excellent. Well, that's really interesting. Clearly, they've seen the value of having some clean stock. So, which had expected. And just, I think this is a follow-up question. And the question is actually, was the process easy to implement? But now you've implemented it, would have done anything differently to make it easier?
There's always little things that you could do differently. Things like that, we started off with them phoning the desk, but obviously if Gwen or whoever's sitting on the desk has gone for a comfort break, or is going to make a cup of tea, or gets called to the office for whatever reason, there may not be someone there to answer the phone. So, you know, the runners weren't dispatched. So that's when we got them radios and started using radios. Found that a bit more effective, you know, and it's just little small things like that. My main challenge now is to sell it to where we can have the funding and the physical space to carry it on and have it be a permanent fixture now, instead of just a trial. Because what I'd like to do, New Cross is, if you've never been here, it's not a vertical hospital, it's a horizontal hospital. So we don't have a lot of tower blocks of wards. Everything is quite spread out. So what I'd like to do is have one, I have two total centers, one that services one half the hospital and another one that services the other half. So geographically, we're in two locations and be able to link in together. So my challenge is to sell that to the ones that hold the purse strings and dedicate space for things.
Okay, and there's just two questions which is about the same thing. Is asking, you know, what kind of advantages, you know, you guys seen in using hydrogen peroxide technology or Proexide, and how easy was it to deploy the equipment?
How easy was it to what? I'm sorry.
To deploy the equipment, to use the Proexide, the hydrogen peroxide process, and to use that to decontaminate the beds.
That was probably the easiest part. We've been using you guys' HPV machines, Deprox, before the current one for that many years, and we've got that many members of staff trained on it. You know, that was simple. That's just the same process as it always has been, to put the stuff in the room, set up the room, you know, seal off all the vents and tape up the doors and all that sort of stuff, and set the machine off, and then obviously follow up with checking levels before entering, you know, airing the room out, that sort of thing, and then that bit is done. The biggest problem we probably had really wasn't that, was to find suitable covers to go over the clean equipment. especially with push procurement and mattress covers and stuff being in different PPE and supplies and stuff not being readily available during COVID.
I think your point, if I could just jump in there, is that around the HPV is because you had a pool of equipment, there was no downtime in adding that HPV to the process, because dirty equipment was arriving into the dirty store, and immediately the clean equipment from the clean store was sitting there ready, and the runners were taking that back out to the bed space that is being turned around, so that equipment worked its way through the process. It's nice to have a fast HPV decontamination process, but in this program, that only helps the flow through the PEC centre rather than the flow of patients, didn't it?
Yeah, that's right. Since it's a 17-bedded ward, we always have at least 17 beds on the ward. So as one comes in, another one goes out. So, and that's one of the things that we were able to sell to capacity and the people that were concerned about being able to turn this back into a ward. We said, well, at the end of the day, it's actually better protected because there will be people in there with it. No one's going to come on and take these beds, and other than the ones that we're tracking. So there's always 17 beds there, and sometimes a bit more, because as now we've linked in with medical physics, as they're repairing beds, instead of them cleaning them and getting them back into circulation, they just bring them straight to the PEC center.
And there's just one question.
We clean them first.
Just one more question that just came in. It's just how many bed spaces have been able to utilize this service, and what is the average monthly cost through the COVID period? And what is it the anticipated cost now the COVID is on the decline?
I haven't been able to identify the specific costs based on the PEC center. To be honest, I just haven't even had time to capture that yet. And I've just had conversations, obviously, with my finance person about that. It honestly really isn't that much more, because we already had the bed cleaning teams and stuff in situ anyway. So we already had those whole-time equivalents in the budget. So the additional has just been the 4 members of staff that are working on the PEC center and that supervisor. So realistically speaking, because between my substantive staff as well as bank, I've got 350 to 400 members of staff. So 5 additional members of staff, it's just a drop in the ocean for me. Obviously, there's a little bit more consumable charge, but it's not that much. We've only had to have the outlay of the radios as well as the mattress covers, because the additional bed stock was already in situ on the ward anyway. We haven't had to purchase that. And then we already had the contract with you guys to provide the HPV machines, so they were already here. So it's just a matter of providing a little bit additional consumables for the HPV machines.
Excellent. Well, I think this is about the time we got for this. So I really enjoyed this, Amy. It was really nice to listen to you guys, and thanks, Corrado, for your insight as well. Yeah, with that in mind, I guess, thank you all for joining. We're obviously going to share this recording, so if any of you weren't able to join, there will be a recording that you can watch and when convenient. So thanks, Amy. Thanks, Corrado.
Thank you. Thanks, Amy.
Thank you.
See you soon.
Thank you.